This is one of the topic I'm passionate about, and whenever a patient whenever the patient defaults or stops treatment, my blood pressure goes up. So we all know about TB. It was discovered by Robert Koch. He called it Koch as in 1882. But even after around 140 years, the challenge remains. The challenge of treating it, challenge of controlling it, challenge of eradicating it. National TB program has failed. Revised national TB program is going on, and challenges remain the same. So India is the capital of tuberculosis with a maximum incidence of TB. So 2.2 million people are there in India, and they can contribute around 30 to 35% of total world TB population. And we lose one person every 2 minutes. So, and all of you will agree with me, the data sound dangerous. The data is really difficult to believe, but this is the fact. All of us, you being the physician, you being a chest specialist, our OPDs are full of patients who are having TB, proven TB, suspected TB, latent TB, hidden TB, MDR TB, and now XDR TB, and there are 2 case reports of pan-drug resistant tuberculosis from India, from Russia, and from high incidence TB countries. So we are fighting, it's rampant, and the fight has to be equally intensive to fight the demon. And demon is within us, because in India the problem is about the average practice. The problem is about the protocols. All of us is treating TB, but the percolation of knowledge, the percolation of fact is slow. There are other administrative issues as well, which all of us know working in government setup and private setups. So despite of all the odds, we have to fight it, because sometimes, someday, somebody very close to us can be a victim. Almost 50% of Indian population is infected, and almost 30% manifest the disease some point of time, whosoever is infected. So it can be us. We being the doctors are the very easy target. I will not repeat it. India is the highest TB burden country, accounting for nearly 1/5 of the global incidence. This is something from our pathology class. Bacteria goes inside, inhale, macrophages engulf it, macrophages become together, form a granuloma. If granuloma, the body immunity, kills all the bacteria, we are safe. Few of them still left. Some point of time our immunity goes down, the granuloma caseation bursts, and this last, and there is spread of TB bacilli into the body. I will not go in detail. So that is the basic pathogenesis. We know about it. But patients send it as an umbrella thing. But if the patient is giving you history of second-time TB, have a strong contact history or history of exposure, please send it for gene expert. You will get the results in India. All said and done, the results are available after 5 days. 5 days you can give the patient conventional 4 drug. After 5th day, you have a report with you on the basis of which you can have a patient or start him on MDR TB regimen very early, and save 3 months, precious month time, because you will declare him MDR once you have given him treatment for 3 months, and he will be clinically deteriorating, or his X-ray will be deteriorating. Then you will, antennas will go up, you will send for a TB culture, which will take 6 weeks to grow, and then 10 days to get the conventional sensitivity report in your hand. So my suggestion to all the practicing clinician is that if your patient doesn't show desired improvement in first 4 to 8 weeks, just have your antennas up and send gene expert at that point if you haven't sent the gene expert in the beginning of your treatment. There are limitations of diagnosis. Sputum examination difficult. Skin prick test only detects latent TB. Even if you are BCG vaccinated, skin prick test or tuberculin test or Mantoux, which we call it, can be positive. We have an interferon gamma assays, but they are very expensive. They are 3,000 to 5,000. In Indian population, it means I don't justify use of interferon gamma in all of my patients. But gene expert, if you have a high suspicion of MDR-TB, please get it done. So we have already talked about these. Line probe assays is the last one. Khatri test and CTB test. CTB test is about interferon gamma. Always said add streptomycin if the patient is a defaulter, which is on the basis of the facts. On the basis of very facts is not apparently a correct measure to control a population of bacteria who's already showing signs of resistance. So after 2009 WHO guidelines, so it is not percolated so well into the practice. We still do that. We still do add streptomycin to 4 drugs if patient does not show desired response. Technically, this is not the right step. Category 3 disappeared. It happened since 2009, but in our practices, this never happened, unfortunately. But now we have gone a step ahead. It is not category 1, 2 or 3. It is sensitive bug or resistance bug. Out of resistant bug, whether it is H resistance or R resistance or both. If it is both, it is a clear-cut case of MDR, multi-drug resistant TB. So by definition, if the bug is resistant to H and R, it is multi-drug resistance. If we send the sample for gene expert which only tells about R resistance, we consider H is resistant anyway. If the patient shows R resistance, we have to treat the patient as MDR resistance. And this is the latest classification of drugs. This is the older classification. Group 1, Group 2, Group 3, Group 4, and now we have this 2016 new drug classification.
What about the treatment which we are using these days in the hospitals? That is short-term chemotherapy, which is given only for 6 months. Is it successful or not? I will tell you my own experience that I get 1 or 2 patients every day, those who have taken this treatment for a sufficient period of time, but they still test positive. The hospitals stop giving them treatment because they have already completed it. And what should we do in those patients? And what treatment should we use?
So very relevant. It's a very relevant question. I hope we all of us feel the same way as he is feeling. The reason being, India being a high INH resistance zone. The resistance to INH is more than 3%. So we come into high INH resistance zone. So when we give treatment for 6 months, the continuation phase has 2 drugs, R and H. So virtually we are treating the bacteria with single drug, which is rifampicin only. So now WHO has come up with the treatment in area which are high resistance for INH. They should have a continuation phase for 5 months and should have 3 drugs, R, H and E. So in my practice, I have started doing it. I treat the patient as intensive phase for 3 months. in which I give 4 medicines, H, R, E, Z, and for 5 minutes I treat with 3 medicines, which is H, R, and E. Most of the time we are unable to get the sensitivities done, but since we are into high NH resistance zone, I would suggest that you can also take the same strategy and treat those patients at 3 months. Because my juniors, my colleagues, my residents, they just follow the same thing. So every time I initiate a patient on anti-TB drug, I write the plan. 3 HREZ, 5 HRE. So nobody changes it. And not many people understand that H resistance and a single drug in the continuation phase, the fall and rise phenomena happens and TB bacteria regrows. So that is the reason for failure. I hope I clarified.
One more point that given on alternatives.
Sir, you are right. As per the latest guidelines by the WHO, though it is being started, it has already been started by Government of India to stop 3 days, thrice a week program, but it will take another year or so before it will be daily dosing program. So it is contributing to the failures. Your experience is, is right, is correct. Yes, sure.